The last medication we will discuss is naltrexone. Naltrexone is less effective for opioid dependence than methadone and buprenorphine because the most difficult part of this medication is that it requires somebody to be off of opioids for at least a week. Extended-release naltrexone serves as a mu-opioid receptor antagonist, and therefore it is a blocker of the receptor. If somebody starts to take opioids, they will not be able to bind. The dose is 380 milligrams in alternating gluteal muscles every month. Unlike buprenorphine and methadone, injectable naltrexone is not recommended in pregnancy. A benefit of injectable naltrexone is that it is effective for comorbid alcohol use disorder. Patients that I've had on injectable naltrexone for opioid use disorder include safety-sensitive positions where opioids are not allowed, such as physicians or pilots. If somebody is in need of opioids, for example, say if they'll have anesthesia, then they will need to have somebody who is skilled in anesthesia available, and a wallet card is helpful to alert people that they are on the medication. A positive of this medication is that it doesn't cause any euphoria, and there is no withdrawal when stopped, but there is also no risk of overdose from this medication. On the other hand, it is very hard to start this medication because somebody needs to be tapered off of opioids for at least a week. For people to get this medication, I usually go to the manufacturer website and locate a pharmacy that is able to administer this medication. I've administered very few personally, but I've learned from the nurse in my clinic ways to improve injection success. Somebody should be relaxed and not tense. When the injection goes in, we should inject into the muscle. The medication should be at room temperature, and the patient is advised to massage the area after the injection. The medication is a microsphere of biodegradable polymers, and so sometimes it can clump up if administered improperly. More commonly, I have seen injection site reactions. If somebody has swelling that does not improve or signs of infection, they should see the ER. Often the reason for injection area issues is due to unintentional subcutaneous injection instead of muscular injection. In this image, we see the steady-state plasma concentrations over 1 month. We can see that after 28 days, as the plasma and naltrexone amount decreases, it's very important for patients to come in because they're going to continue to need their medication. You'll also notice that there are 2 peaks in blood levels. One is 2 hours after injection, and the other is 2 to 3 days after injection. Common side effects associated include nausea, as with most of our medications, as well as fatigue and appetite changes. Rarely can somebody have hepatotoxicity, but that is usually in higher doses. To summarize key points, extended-release naltrexone is an effective medication for opioid use disorder and alcohol use disorder, but is less effective than methadone and buprenorphine because the most difficult part of this medication is that it requires somebody to be off of opioids for at least a week. The medication is especially useful for people who are in safety-sensitive positions such as pilots or physicians or who cannot take opioids. As with all medications for opioid use disorder, staying on the medication longer will lead to better outcomes. Administration is through the gluteal muscle injection, and generally the manufacturer website has locations of pharmacies that can administer it.